The problem is SD is in the brain, and all the treatments that we have are really targeted elsewhere. Treatments that we have for the brain really sort of haven't made it to prime time yet for SD because we really don't know where in the brain it is. If we look at sort of way other brain or movement disorders have been treated with ablations or implanting of foreign tissue, that really hasn't been done, nor would we really know where to do that. Deep brain stimulation has been postulated. I think we'll hear a little more. It's been done for tremor, I think a handful of times with some variable results, and to my knowledge, it's not been done specifically for SD. But that probably is the future once we figure out where in the brain that we're going to target. So as you know, therapy focuses on speech therapy, medical therapy, and surgical therapy, and all this stuff is symptomatic. And we've heard about the limitations, about Botox and why people have problems with Botox, and that seems to be the main driver for people that are seeking operations, that they're having issues with Botox. So Botox isn't permanent. So some patients want it to be permanent. We've heard about this roller coaster, and Dr. Paniello's study has been talked about a number of times, and Dr. Blitzer kind of talked about how to optimize this, but this was his study where, he shows that patients get in these cycles where there's a downtime. They never get really well. Only 14% of these patients had very high quality of life at any time. And then I did a study with my colleague El Moradi looking at technique of injection, and although when we compared techniques, everything was good, and we had about 95% success in injecting, it was interesting that still a large chunk of our patients wanted some adjustment to the Botox. They weren't really happy, they wanted it to be a little bit better. And that's sort of one of the issues with Botox. People always want it a little bit better. Some other issues, what's in the bottle? I just learned this recently. We get the bottle of Botox and it's supposed to have 100 active units. Turns out that that's not always the case. That apparently can vary up to 10% depending on the lot and things like that. There's issues with placement, variability of the disease, tachyphylaxis antibodies. And patients have difficulty in accessing Botox. In Wisconsin, I think it's myself and Dr. Daly probably do 95% of patients in the entire state, and they have to come to us. So it's hard to get to us, and there's economic factors, for patients, for practitioners. It's, to open up a bottle of Botox for a practitioner, if you're not doing it all the time, it costs a lot of money. And patients don't like the inconvenience. We've also heard this, what if my Botox doesn't work? What do I do now? And I think it's really up to the practitioner to discuss and figure that out. It's not, the first alternative is not necessarily to go to an operation. So there's definitely an art and a science to delivering Botox, and a lot of ways that we can deliver it: unilateral dosing, bilateral dosing, high dose, low dose, et cetera. So, but that does get us to operations. And so what are our goals? If we're going to do an operation, what are we going to try to achieve? We want a permanent solution. If Botox, one of the main caveats is that you have to repeat it. It'd be nice to have something more permanent. Obviously, we want a good postoperative voice. We don't want to sort of trade patient's voice quality for the procedure. And avoid the long-term complications. The larynx does three main jobs. It allows us to talk, it allows us to breathe, it allows us to swallow. And once we sort of alter some aspect of one of those issues, we usually sort of have collateral damage with some of the other issues. So we have to really sort of pay attention. What are really the ways that surgery has been sort of patterned around? We adjust the biomechanics of the larynx. So, and this is primarily for adductor, but basically if you have muscles that are closing too much, we're just trying to loosen them up. And we can do that mechanically just by moving things apart, or we could do that somewhat physiologically by altering the nerve input or the muscle tension. And that's kind of what Botox does. It alters that the muscle tension there. So for adductor, I kind of split things up into nerve muscle techniques and mechanical techniques. For nerve muscle techniques, there's the unilateral recurrent section, which is the oldest technique. There's the selective laryngeal adductor denervation or renervation procedure, or otherwise known as the SLAD. And then there's these myomectomy, myoneurectomy procedures that can be done through the mouth or through the neck. And then mechanically, we can separate the vocal cords, yank them apart with a type II thyroplasty. Nerve section does have a history. It predates Botox. It was one of the initial papers from 1976, and it sounded great. However, when other people started doing these procedures, they really didn't get the sort of same excellent results. And in fact, it seemed like a lot of patients were trading one type of voice disorder for a different type of voice disorder. So we see a lot of patients with vocal cord paralysis, kind of a breathy voice. So if you're willing to kind of trade your SD voice for kind of a breathy voice, then maybe a unilateral section is okay. And then that procedure was modified with crushes and different types of resections with some benefits. And then the selective procedure came on board, and this is going back to the early 90s. And the idea was to try to do something that's similar to Botox. So Botox, we target the laryngeal adductors, the TA, what we call thyroretinoid and lateral cricoretinoid muscles. So what if we go in there and we cut those little nerves, and we do that on both sides, and then we do some other things to kind of avoid some of the problems that we saw with the unilateral section. We kind of plug in a new nerve into that area so you don't get the atrophy, and actually trim one of the muscles. We do a little myectomy with that as well. And that has garnered some good success. It's been done now since about '93, so a good 20-year track record now. The largest study that came out of UCLA, we looked at 83 patients, and 91% were very happy. When we took pre and post voice data to blinded observers or listeners of the voice, we also had very good results. Not as good as the happy factor, but no voice breaks in about 3/4 of patients, and there was some breathiness in about a third or 30% of patients. So what are other approaches? Myectomy, myoneurectomy, these are sort of garnering some more press lately, largely developed in Asia and then in Brazil, where basically you cut some of the muscles that go to the vocal cords. And some, again, there's some smaller groups with excellent results. This is a very typical approach that we do for a lot of things in the larynx. It's very easy for us as laryngologists to go and operate near the vocal cords with a laser and remove tissue. At least in the sort of the smaller studies that have come out of Asia, this has worked really well. Not a lot of comparison. Type 2 thyroplasty, you've probably heard of this. This is mostly popularized in Japan, also done somewhat in Australia, maybe less so in this country, where you basically yank the vocal cords apart, put a small shim between the front of the vocal cords, and that's sort of the larynx looking at the top. So if you yank the cartilage apart, you could put something in there to hold it apart. And originally it was designed with a or a plastic kind of thing, and now they're using a titanium bridge. And they're, again, showing some good results. I've done this, and it's a pretty easy case for us to do. Again, these are techniques that we're used to doing for vocal cord paralysis and other very common disorders that we deal with. There's an advantage that they're potentially reversible. They're titratable. We can adjust the patient to the problem, or the problem to the patient. But the data, like a lot of these things, there's some small groups of patients with very good results for somewhat short term. There was one counter paper that showed, and this was also, I want to say, my personal experience as well, that patients fail in these procedures if you follow them out a year or two, because basically they overdrive the system. You could yank their vocal cords only so much before they get some breathiness, and then eventually they kind of come back with the muscle tension or some of the other changes. So they didn't seem to last in one of the sort of counter studies. The group that sort of started this out say, well, they think that the failures were due to stylastic or using plastic instead of metal. I don't know if I buy that. Abductor, you got a bigger problem with the operation. Overtreatment of the muscles that are involved in abductor doesn't allow you to breathe. So if everybody was willing to trade or improve their voice quality for a tracheotomy, I think we could do fantastic, but that's probably inappropriate. So there really are no nerve procedures that have been described. There are a muscle procedure where you basically can trim that muscle. Obviously, you need to be careful so you don't overdo it so patients can still breathe. And then type 1 thyroplasty, as discussed. So there's only really one paper on adjusting that PCA muscle with 3 patients. One did have a tracheotomy, so there's a major complication with that. And they did have some improvement. I've actually done this procedure twice. We didn't give anybody a tracheotomy. One patient we seemed to improve. The other patient we didn't. I'm not very enthused about this operation. Type 1 thyroplasty, we talked about, is a very common operation that we do for vocal cord paralysis. Again, brings the vocal cords closer, and it probably is an adjunct to Botox. So, Botox treatment is effective for a majority of patients, but it's not with that issue, and you guys all know the issues. And if you do have a problem, it's important that you talk to your physician about it, and you get together and figure out how can you optimize that treatment. If you're thinking of operation, there are operations out there. They can be highly effective, but it is a big leap. Operations by their nature are destructive. We do things that change things permanently, and so you have to take that into consideration. You don't approach these casually. What are the various pros and cons? I see it as an option. I treat most of my patients with Botox, but Still, some patients want something else, and so this is something that we can do. In Botox treatments aren't all that grand. And I must say that the operations, in my experience, are excellent in reducing the effort of phonation. A lot of patients, when I talk to them, I ask them what's the biggest problem, and I usually try to ask that very open-ended, and it's not so much the vocal quality, it's the effort of speaking. And I must say these operations are really good at fixing that or relieving some of that effort. The arguments against operations is that botulinum toxin is a reversible treatment and it's more minimally invasive, perhaps. Botox does work for most patients, and we should optimize treating our failed Botox patients rather than just operating on them. Dystonia is a central process, so again, we are just treating the symptom, and so an operation might be a little bit overkill. The dystonia can change over time. An operation is treating you at one point in time, and what happens in the future, we don't know. And the data from the operations could be more robust, and that's one of an ongoing problem. And I just made a comment that that's always going to be a problem because the patient numbers that seek operations are ultimately going to be small. The data tends to be retrospective, sort of what we saw in our patients, and that data is less robust than what we call a prospective study, where we separate patients into randomized groups. There's always going to be patient biases and surgeon biases. So I do certain operations because I know how to do them, and I think I know how to do them well. I don't do other operations because my perception is they don't work, and so there's my biases. There's patient biases. When patients come to see me for an operation, they want that operation to work, and so that's part of it too. And it's also difficult to compare the operations. So if you ask me what operation's better, the SLAD or the thyroplasty, we have no way of knowing. And that we're never going to have robust enough data that we can equally compare them. And that's actually true with a lot of things in the surgery world, that it's hard to compare different operations. So last thing, we're still treating the symptoms, and until we sort of get to the brain and figure out what's going on in the brain, everything's going to have a limitation. So I did that in 12 minutes.